Thank you to the Wolfeboro Lions Club for underwriting Nutritional Wisdom. The Wolfeboro Lions Club is committed to helping the community with health concerns such as diabetes prevention and preservation of sight and hearing. The Wolfeboro Lions Club meets on the second and fourth Tuesday of the month in the 1812 room at the Wolfeboro Inn. Members of the community are encouraged to attend meetings or visit the website e-clubhouse.org/sites/Wolfeboro for more information.
Hi, this is Patty Walker, registered dietitian and your local community nutrition expert, welcoming you to another edition of Nutritional Wisdoms. Today our topic is going to be about diabetes and eye health. I am very excited to introduce our guest, Dr. Cynthia Lawrence from Laconia Eye and Laser Associates. Welcome, and would you mind telling us a little bit about your practice?
So thanks for having me, Patty.
Yeah.
It's great to be here. I'm in a group practice with 3 ophthalmologists and 2 optometrists.
Wow.
And we have locations in Wolfeboro and Guilford and Plymouth.
Nice. All right. Well, before we get into the details about diabetes and eye health, I think it would be best if we start a little bit of review about exactly what diabetes is and the types of diabetes that are more common. So I know in my practice, most people come in and I ask them what diabetes is, and they say, oh, it's high blood sugars. But it's so much more than that.
Absolutely. High blood sugar is actually caused when the body either doesn't make enough insulin or can't use the insulin as well as it should.
Yeah, and just to clarify, insulin is a hormone produced by our pancreas, and its primary role is to regulate our blood sugars, to get the blood sugars back in a safe range. So what I think of insulin as, it's like a key that unlocks the cell doors. And we need insulin to be able to unlock the cell doors for the glucose to get in for energy or storage. And without the insulin, the blood glucose or blood sugars get too high.
That's right, and that's what happens in people with type 1 diabetes. Their pancreas stops making insulin altogether, and type 1 diabetes is an autoimmune condition, and generally it's diagnosed in childhood. It makes up about 5% of the diagnosed cases, and people with type 1, they need to take insulin to survive.
Oh, that's absolutely true. I actually, a funny story, I was doing diabetes classes, and I had this woman who took insulin. So just because you take insulin doesn't mean you have type 1, and I'll explain what type 2 is. But she was on vacation, and she said, I just don't know if I'm a type 1 or a type 2. And she went on vacation and forgot her insulin. And for a week, she did not have insulin. And so I said, well, that's a very good sign that you're a type 2, because a week without insulin for type 1, it's not possible.
No.
So type 1 is definitely autoimmune, and they need insulin to survive. But type 2 is the more common condition. It's about 90-95% of the diagnosed cases, generally diagnosed in adulthood, but we're seeing more kids and teenagers diagnosed with it because it's more related to lifestyle choices, your weight, your activity level. So there are risk factors for type 2 diabetes, but just realize that type 2 diabetes is definitely more associated with lifestyle conditions, and it is preventable. But with either type of diabetes, high blood sugars cause complications.
Definitely. And without enough insulin, the blood sugar levels become too high, and elevated blood sugar can cause damage to very small blood vessels that are in the body, and then you get a lot of complications from that.
Yeah, so what are the complications that you're most familiar with?
The major ones would be heart attacks and strokes. They're the most common. But there's a lot of other ones. There's kidney failure.
Yep.
Blood vessel disease results in amputation of limbs and other body parts. I'd like to avoid that.
Yeah. I'd like to avoid all of these.
Yes, yeah. There's nerve damage, especially in your hands and feet. You get a lot of tingling and numbness and pain. And impotence in men.
Yep.
And then there's also it's the leading cause of blindness, or a leading cause of blindness.
Yeah, gosh, those don't sound too wonderful.
No.
We want to avoid those. But I've actually had clients who have complained about blurred vision and haven't had diabetes. Is that common?
It is common, but it is very common to find that they have blurred vision, and that is a sign that they have diabetes, and they may not know that they have it.
So what do you do with those cases?
So the blurred vision often prompts people to go in and see an eye doctor, and if we see there's like a big change, like what we call a myopic shift, where suddenly you're more nearsighted, that kind of triggers to us to think, oh, maybe the blood sugar's high and they're diabetic. So then we send the patients back to their primary care doctors to get blood work done and check out their levels and check for diabetes.
Yeah. So is that type of blurred vision, is that permanent at that point?
No, fortunately, once you get your blood sugar levels back in order, your vision can return to baseline, back to normal.
Excellent. So blurred vision is due to a buildup of fluid caused by high blood sugars. Is that correct?
Yes.
Okay. And it can occur before a person even knows they have diabetes?
Oh, definitely. Yeah.
Wow. All right. So before we get into how diabetes affects our eyes, I think it would be really helpful if you could explain how our vision works.
Yes. So the eye is a ball covered with a tough outer membrane. The covering in front is clear and curved. This curved area is the cornea, and that focuses the light while protecting the eye. After light passes through the cornea, it travels through a fluid-filled space and then travels through the pupil. The light continues through a lens that focuses it even more. Finally, the light passes through another fluid-filled chamber in the center of the eye, and that's called the vitreous. It strikes the back of the eye, which is the retina. The retina records the images focused on it, and it converts those images into electrical signals, which the brain receives and decodes. One part of the retina is specialized for seeing fine detail and color, and this tiny area of extra sharp vision is called the macula. Blood vessels in and behind the retina that nourish the macula.
Okay, well, gosh, I know I've heard of retina and macula, those terms before, but I really hadn't understood what they were, so I really appreciate that, and I like the picture so I could follow along with that. So thanks for detailing that. But let's dig a little further. I know that diabetes can affect our vision, and I, as a diabetes educator, have been taught about retinopathy, not really sure what it is, and we're going to talk about that. But are there other common eye conditions that a person with diabetes might be at increased risk for?
Yes. So many people without diabetes get cataracts. It's just a normal thing that we get with age. But people with diabetes are much more likely to develop them, and at a younger age.
So what are cataracts?
So cataracts are when the clear lens becomes cloudy inside the eye and it blurs your vision. And when it affects the vision enough, then you need surgery to remove that lens to correct your vision again.
As I cringe here thinking about surgery. Okay, so cataracts is one. Any others?
Yeah, another condition is glaucoma, and that's a condition where it's a progressive damage to the optic nerve in the back of the eye, and that causes loss of vision as well. And it occurs more often in people with diabetes than the general population. And that's because you get this damage to the very tiny blood vessels in the back of the eye, which then damages the optic nerve and causes that vision loss. The leaky blood vessels can also form in the front part of the eye where the fluid filters through, and it can create a higher eye pressure, and that high pressure then damages the nerve and makes you lose vision.
And peripheral vision.
Peripheral vision, yes, but if it proceeds long enough, then you can lose central vision too.
Goodness. Okay. And the big one that we really need to talk about is retinopathy. So what is retinopathy?
So, retinopathy is damage to your retina, and it takes time, but diabetes damages the blood vessels in the retina, and it's when these teeny little blood vessels start to leak. They leak blood, they leak fluids, and this causes the retinal tissue to swell.
Okay.
And with the swelling, you get cloudy or blurred vision. And so the condition is generally in both eyes. It may be worse in one side than the other, but it's generally bilateral. And the longer you have diabetes and the worse control you have of your blood sugar, then the more likely you are to develop the retinopathy. So if you leave it untreated, it can actually cause blindness.
Oh, goodness. Well, I actually have seen that firsthand in my practice. Years ago, there was a gentleman that came in with a history of uncontrolled diabetes, and the doctor sent him because he needed to start on insulin. He said, but he's not going to be able to because he can't see the syringe, the markings on the syringe.
Yep.
And fortunately at that time the insulin pens had just come out, but I mean, the gentleman was fine about taking the insulin because he could listen to the clicks on the pen and have his wife verify that, yes, that's the right amount of units. But all he really, really wanted was his eyesight back. And I couldn't offer that to him. I could just offer him a way to prevent further deterioration.
Right. I mean, the whole thing about keeping your blood sugars under control, that's the key.
Yeah. So warning signs. I know with diabetes there are some warning signs like increased thirst or urination. Are there any warning signs that you might have diabetes retinopathy?
Yeah, I have a slide that lists these. Some of the symptoms of retinopathy would include seeing spots or dark strings in your vision. Some people call them floaters.
Okay.
You can have blurred vision, or your vision can fluctuate. Your colored vision can be impaired, and you may have a dark or empty appearing spot in the center of your vision.
Yep. And
you could have difficulty seeing at night too.
Okay. Wow. There's a lot of potential symptoms there.
Yes.
Yeah. And the other thing I really want to emphasize is that just because you have diabetes does not mean that you're going to get all these horrible eye conditions.
Right.
In fact, our hope is to prevent retinopathy from happening, and glaucoma and cataracts, but prevention is very, very important. So are there risk factors that people should be aware of that may increase their risk for developing retinopathy?
Yes, there are. And one of the big ones is just poor control of your blood sugar. And that is critical to keep that under control. Also, high blood pressure and high cholesterol. And I'm sure that you help all your clients with all these things.
Well, that's true. And I often find that clients that come in with diabetes also have one, if not both, of the other two conditions of high cholesterol and high blood pressure. And it's very common for their physician to treat all three conditions, whether they have one or the other. Like I see clients that will be put on blood pressure medicine for preserving their kidneys, or cholesterol statins, even though their cholesterol is fine, just to protect from these complications.
That's right.
Yeah.
Yeah, and that's really important. I mean, diabetes can be overwhelming, and, helping to manage it is really vital.
Yeah, I try to help my clients think about knowledge is power, and that if they have diabetes, they are the driver of a bus. And the people that they want to help with their control are the passengers on the bus, because if you have diabetes, you are in charge of your diabetes. You make hundreds of decisions every day that will affect the outcome of the blood sugars. So people who you might want in a bus would be a dietitian, a certified diabetes educator, an eye doctor, certainly your PCP. Some people need an endocrinologist, which is a person more specialized in diabetes. You would want a foot doctor. But in addition to professionals, you also want your family and friends. You need support. So in the ideal scenario, a person that gets diagnosed with diabetes would come to see a registered dietitian 2 to 4 times the first year, just to set up some lifestyle, good habits and get these in place. But in addition, you want to have follow-up annually, or at least when there's a major change in your diabetes, because the people that are proactive in their diabetes are the ones that have the better control. And Medicare actually covers 3 hours the first year of education and 2 hours every year thereafter of nutrition education without a copay for you to get better control, because the goal is to prevent long-term complications. And most insurance companies also have a diabetes benefit. And, realize that as the client, the person with diabetes, you get to choose who you see. So you can ask the referral to be sent to any person that covers or has these insurance providers. But getting education, having an annual eye exam is so critical. Any other risk factors for retinopathy?
Yes, there's a few more. The duration of the diabetes is huge. The longer you have diabetes, the greater the risk you're going to have of developing retinopathy.
So you see people with type 1 that's usually diagnosed earlier
Unfortunately, yeah, because they've had it at such a young age. And it's that all those years of just wear and tear and
Yeah.
yeah. There are some other risk factors. Pregnancy,
Wow.
yeah, tobacco use, and
So getting back to pregnancy, is it persons that have diabetes while they're pregnant are at increased risk, or all pregnant women are at increased risk for retinopathy?
well, if you have a tendency to be diabetic, and you can have a pregnancy-induced diabetes,
gestational diabetes,
yeah,
yep.
gestational. These are things that can, give you a higher risk. But to have a higher risk of having retinopathy, you would generally have to be a diabetic
Okay.
and be pregnant to make it worse.
Okay, so
Makes
no
sense.
question's a stupid question, okay?
Okay, so tobacco use.
Yeah, smoking would
yep.
definitely be a risk factor.
And being African American and Hispanic and Native American also gives you higher risk.
Yeah, those ethnic groups actually have a higher risk for diabetes altogether.
Yeah.
Yeah. So how about the different types of retinopathy? Are there more serious or less serious types? What are they?
Yeah, there's two main types. The first is non-proliferative diabetic retinopathy, and that's the early stage of the disease. And you might have symptoms and you may not. In non-proliferative diabetic retinopathy, the blood vessels in the retina, they're weakened, but no new blood vessels are forming yet. Tiny bulges can protrude from the vessels, and the walls of the vessels get leaky. And you might get fluid, you might get blood that leaks out into the retina.
Yeah.
Yeah.
And I think you actually brought a picture of the two different types.
Yeah.
Okay. All right. Great. So hopefully that's going to be up there for the viewers to see too.
The larger retinal vessels can then begin to dilate. They get irregular in diameter, and your non-proliferative diabetic retinopathy can progress from mild to moderate to severe forms.
Okay.
As you're getting more severe, your nerve fibers in the retina may begin to swell, and sometimes the central part of your retina, which is called your macula, that gets swollen, and that causes very blurry vision, and that is called macular edema, and that's a condition that requires treatment.
Okay. All right.
The other type is proliferative diabetic retinopathy, and that's the more advanced form of the disease. And at that stage, the circulation problems deprive the retina of oxygen. And as a result, new fragile blood vessels can form, and they can grow into the retina and into the vitreous gel. And if that happens, these vessels can leak blood into the vitreous, you get clouding of the vision, you get hemorrhages in there, and it can really cause a lot of problems with that.
So you just don't see.
No, and you can get retinal detachments, you can get scar tissue that forms in there, and it also can go towards the formation of glaucoma.
Yep.
And we've already touched on that a little bit already.
Yeah. So how do you get diagnosed with retinopathy?
So diabetic retinopathy is best diagnosed by having a comprehensive dilated eye exam. We put drops in your eyes to dilate the pupils, and then we can get a good look at everything inside the eye. If anything looks suspicious, if it looks like you've got any retinopathy that needs any treatment, then you might need some additional tests after that.
Okay. Is retinopathy, is the damage permanent? Is it treatable?
It's treatable. You can't necessarily cure retinopathy, just like you can't cure diabetes. You can control it, but you can't necessarily get rid of it.
You can't turn back the clock.
Exactly. Now, the whole goal of treating is to kind of stop progression and slow it down. You can reverse it a little bit if you catch it and soon enough, but you're not going to completely cure it.
So the importance of annual eye exams, and oftentimes more than annual.
Right. Yeah. If you look very suspicious that you might progress from one of the milder stages into a more severe stage, we may see you more frequently than once a year. But otherwise, if you're in a pretty mild to moderate amount of retinopathy, at least once a year is recommended.
Okay. And the treatment, how do you treat?
So if you have mild to moderate retinopathy, you might not need to do anything other than monitor it.
Okay.
We take photos and we watch. And if you have anything going on, then you might progress into more of a proliferative type. And if you have the proliferative type, then you can get macular edema, and then you need some surgical treatment for that.
Okay. Well, hopefully we'll prevent that.
Yeah.
And the complications, I think you touched on some of those already.
So you could get a vitreous hemorrhage with blood leaking inside the eye. You could have a retinal detachment, and you might have glaucoma, which we talked about a little bit, and worst of all, blindness.
Yeah, we don't want that.
No, not at all.
All right. Well, I really, really appreciate all this wonderful information you've given us. Because I often think of diabetes as I wish I knew then what I know now scenario. People want to turn back the clock and say, well, nobody told me, or maybe they weren't listening, but complications are real with diabetes, and prevention is paramount. So, can a person with diabetes have good eye health?
Yes. Yeah, it's all about the control. And keeping your A1C under 7% will make a huge difference. And annual eye exams.
Yes.
You know, that way we can monitor and we can stay ahead of any issues that might arise.
Yeah, that's great. And I'm actually really, really glad you brought up that A1C. Most people with diabetes understand what the A1C test is. It's actually a test that gives a look back at your previous 3 month of blood sugar control. So you don't have to fast for the test. So it is a way that we can evaluate what's been going on for the previous 3 months. And the test actually was designed to look at your risk for long-term complications. And they know that keeping the A1C at 7% or lower really reduces your risk for long-term complications, but that value is individualized depending on your state of diabetes. If you're 45, we might say we want that A1C at 6 or 6.5%. If you're 85, we may say 8% is fine, because it really evaluates your risk for long-term complications. And it's, long-term complications can come on and occur slowly, but the damage is permanent. And the thing I really want to stress is that for every point above 7% on your A1C range, so between 7 and 8%, you have a 37% increased risk for nerve, eye, and kidney damage. If you're, it's huge, but then it goes on. If you're 8.5, so between 8 and 9%, you have an additional 37% increased risk for these conditions. So as you're saying, blood sugar control is paramount.
It's key.
But also understand that getting better control reduces your risk by that same amount. So if your A1C is a 10 and you get it down to a 7, you have reduced your risk of these small vessel complications of eye, nerve, and kidney damage by 37% threefold. So it's not, we really, really want to help you with good eye, with good vision, but also with good control. And that includes your blood sugars, your blood pressure, and your cholesterol.
Correct. That's
Yeah.
right.
Yeah, so
A lot to it.
there is. So glad you came. You have been paramount in educating not only me, but our viewers in eye health. Is there any final words you'd like to offer us?
Thanks, Patty. It's been a pleasure.
Yeah?
And yes, I would like to say, if you get diagnosed with diabetes, take it seriously and take control. It's the most important thing is that you can keep your blood sugars well controlled. That's the key. Do your best with that. See a registered dietitian and a diabetic educator every year. Get your eyes examined every single year. And if we see anything unusual going on, then we might see you more than once a year. But we'd like to prevent that.
Yeah.
It's very common, and all of the eye care providers in our practice, we see diabetics on a daily basis, numerous generally.
I was going to say probably a good percentage
Yeah.
of your...
Yeah, and if we see anybody who has crazy complications, then we can send them on to Dr. Branchini, who does do the laser procedures and the injections in our office.
Awesome,
Yeah.
awesome. Thank you. And I like to end every show with a recipe, and because we're talking eye health, I thought a simple recipe with carrots, because of the beta-tine in carrots, is very good for your eye health. And so the recipe is coriander roasted carrots. It is super, super simple. The recipe you see on the screen will say 2 pounds of carrots, 2 tablespoons of olive oil, and 2 tablespoons of ground coriander seeds, which is a cilantro base. So if you don't like cilantro, you might want to substitute rosemary. Essentially, all you need to do is peel and wash the carrots and get them into uniform sizes. So I really like to have the whole carrot be roasted because it's a pretty presentation, but you can certainly cut it. And the most important thing is to have the pieces be uniform, because they roast. The roasting part of things would be important for that. Get them in uniform size, put them on a cookie sheet, get a pastry brush, put some olive oil on them, top with the seasoning, and you can put a pinch of a good quality salt and some pepper on, and you roast them at 325. You want to turn them over every 10 minutes, and depending on the size, they're going to be ready in 20 to 40 minutes, and they're ready when you can put a fork or a knife into the carrot, and it goes through nicely.
Sounds good.
Yeah, it's delicious. So anyways, thank you all. Thank you, Cynthia, for being here, and thank you all. Wishing you a healthy day.